I'll get started. Just as an introduction, I am the director of a physiology lab at Upstate Medical University. And I've been working for too long, 35 years or so, on the pathophysiology and treatment of ARDS, and more recently on the impact of mechanical ventilation on this disease, or ventilator-induced lung injury. And so what I'm going to do today is discuss many things, most of them coming from a physiologic perspective, but then our laboratory is very translational in that our animal models simulate ventilator patients that you guys would be treating in the clinic. And being translational, I think anything that we really see in our lab that works would very easily translate into a positive clinical trial. And what I'm going to try to do is, as you can tell from the title, sort of get a whole new perspective of what you can do with mechanical ventilation. Right now we feel that mechanical ventilation is obviously a necessity to keep your ARDS patient alive, but it's also like this evil demon that's also injuring your patient. So I, along with Dr. Habashi and some others, have come up with an idea can we actually use the ventilator as a drug? Can we apply mechanical ventilation to patients at risk of ARDS when their lungs are still relatively normal and actually prevent the progression of the disease? So why is it important to stop ARDS, to prevent rather than treat ARDS? For the main thing is that once established, ARDS is very difficult to treat. As we all know, and a patient with established ARDS is very hard to ventilate and has a very high mortality rate. Almost all clinical trials that have been attempted to reduce morbidity, mortality in ARDS have failed. Low tidal volume ventilation did reduce ARDS moderately, like Dr. Salcida said, it was around 9%. Mortality of ARDS worldwide is still very high, between 30 and 60%. And if you take the higher numbers, the mortality of ARDS is actually higher in breast cancer. So to bring it home that this is a very important disease that we have to keep working on. Also, a recent study demonstrated that in hospitals that are using the low tidal volume ventilation, that the mortality is still greater than 40%. So even with our knowledge of protective mechanical ventilation, the mortality of established ARDS is still very high. And patients that develop established ARDS often have, the ones that live, often have chronic lung and brain injuries. So even the patients that we do get through this terrible disease, they often have a chronic problem for the rest of their life. So this was a study by McIntyre in which he looked at clinical trials. And so this is a treatment modality and the evidence level and his recommendation grade. So he looked at a bunch of clinical trials and to see how they fared. How did this trial reduce ARDS mortality? And he found that the highest level of success was in the low tidal volume or open lung, which he gave a B. The rating system he rated from A to a D, or not recommended if the treatment showed no benefit at all. But really, that's about it. The only really important clinical trials that showed any improvement were the low tidal volume trial. If you look at the other level 1, these are the randomized trials. For extracorporeal support was not recommended, for pulmonary vasodilators not recommended, and for immune modulators not recommended. So the point being is that most clinical trials for ARDS have failed. And if we're keeping score with just this trial, ARDS is 14, a good guy's 1, and so we're not doing very well. This was followed by a study by Dr. Brower, again, looking at treatment of established ARDS. How successful is it? And you can see, you look from 1994 all the way down to 2011. And on the right rating, the NSD is not significantly different. So just quickly, you can see that the majority of the trials intended to reduce mortality in ARDS have not been successful. And although we keep trying, ARDS is still a really tough nut to crack. This is a very recent trial looking at aerosolide beta agonist to reduce ARDS mortality, and the bottom line is that it did not show clinical improvement. Also, a recombinant surfactant protein C You can see here, let's see if this works. Okay, you see this is PO2 and hours, and you can see that they both with the surfactants given here with the little arrows, you can see that the PO2 curve increased about the same with or without surfactant. And again, they show no benefit to the patients with severe direct lung injury. And this, the most recent trial, as Dr. Slutsky mentioned, was on high-frequency oscillation. And again, this is given to moderate to severe ARDS patients, and they actually showed an increase in hospital mortality. Bottom line is ARDS, once it's established, is very, very difficult to treat. So if it's so difficult to treat, can we prevent it? So being a physiologist, you have to start to ask yourself questions. Well, is it possible? Does it make sense that this is a good strategy? So we must understand the pathogenesis. We have to know how the disease progresses in order to understand how to treat it. So we had to ask ourselves these three questions before we got started. What is the role of mechanical ventilation in the development of established ARDS? Does the ventilator actually cause part of the problem? Is there a window of treatment in the hospital where you could actually prevent ARDS? In other words, do people come into the hospital with ARDS already, or do they develop ARDS once in the hospital? If that's the case, well, then it's possible we could treat these patients and actually prevent the disease from regressing. And lastly is, what are the key pathologic components that comprise this pre-ARDS pathophysiology? We have to know the sequence of events going from normal to diseased in order to know where to block and how we can possibly prevent these. First question, what's the role of mechanical ventilation in the development of ARDS? Well, first, following trauma, hemorrhagic shock, or sepsis, we get a systemic inflammatory response syndrome. Blood becomes very high-powered with multiple chemical mediators and white cells. This can lead to an early lung inflammation. When this gets severe enough, the patient's going to be intubated. Excuse me. And once intubated, of course, they're going to go on mechanical ventilation, which can cause a secondary ventilator-induced lung injury or VILI. And so what we're really thinking now is that it's this combination, the combination of this systemic inflammation and mechanical ventilation that ultimately causes ARDS. So we think that the way the ventilator is currently being used, and there's many studies to demonstrate this, actually causes part of the problem, actually drives the lung into ARDS. So some of the evidence for this is that a number of studies now have showed that improper ventilation of normal lungs drives the disease. In other words, these are studies with patients that did not have ARDS, did not have ALI, but were still at risk of developing these diseases, and they were put on mechanical ventilation. In this study by Dieterman, there was two groups. One group had tidal volume of 10 cc's and one at 6. Remember, all of these are without ALI. So a tidal volume of 10 doesn't sound too bad to a patient with normal lungs. But this is what they found. This is PF ratio, time in days. The black dots are the higher tidal volume, the 10, and the clear dots here are for the tidal volume of 6. And you can see over the 4 days, the patients that got the higher tidal volume, and it was just 10 cc's per kilo, progressively had their PF ratios fall. Again, this is time in days, and this is percent without ALI ARDS. You can see many more patients that had the 10 cc's per tidal volume rather than the 6 develop ARDS over a 7-day period. So this is showing that the mechanical ventilator itself is helping to drive the lung injury. Another study by Dr. Hubermeyer's group, again, looking at patients without acute lung injury on mechanical ventilation. Excuse me. So these are patients in the ICU, all without ALI, and they were placed on multiple tidal volumes depending on the choice of the physician. And y-axis is the proportion of ALI, and the x is tidal volume. We found that the patients that developed ALI had tidal volumes of less than 9 were the lowest, and the patients that had tidal volumes greater than 12 were the highest. Again, so tidal volume size in patients with normal lungs drives the lung into ARDS. And this is a paper that I was very interested in. I thought it had a lot of great information by Dr. Alveolar and Slutsky. And so what I want to do is just read a number of quotes from this paper. And the title, as you can see, is Acute Respiratory Distress Syndrome an Iatrogenic Disease? So do we cause ARDS ourselves? And the first quote is they mention that there's unequivocal evidence that mechanical ventilation can cause ALI. And that's definitely a fact. ARDS network did not address if low tidal volume should be used on patients without ARDS. Dieterman, in Critical Care in 2010, suggested small tidal volumes in patients without ALI may be a reasonable strategy. We should begin to consider that ALI and ARDS is a consequence of our efforts rather than a progression of the underlying disease. So in other words, we at the bedside with our mechanical ventilation are helping drive this disease forward. Injurious ventilation strategies have been shown to cause all of the pathologies of ALI and ARDS. So patients that are just on, or animals just on the mechanical ventilator, they develop the exact same disease, ARDS, as a patient that may have a systemic infection. And also that ALI and ARDS is largely a man-made syndrome. And the real take-home quote is that ALI, ARDS is no longer a syndrome that must be treated, but is a syndrome that should be prevented. And really the rest of my study is going to focus on this concept. Is ALI, ARDS something that we can prevent? And if so, how are we going to prevent it? Well, first we have to know, is there a treatment window? Is there time during the patient stay in the hospital where you can actually do something to prevent the disease? Now, this is a study by Shar looking at the timing of the onset of acute respiratory stress syndrome in a population-based study. And so what they have a pie graph, and these are the patients that 67% of these patients developed ARDS while they were in the hospital. So they came into the hospital without ARDS and developed it after. The rest of these 19%, they weren't in the primary care hospital, but they came from smaller hospitals from the outside, from nursing homes. They had been some hospital exposure. So again, these patients were under the control of a hospital environment and they could have been treated. And only 14% of the patients actually showed up at the hospital with ARDS. So the point being is that there is a treatment window. Patients usually develop ARDS in the hospital, therefore we can possibly prevent that from occurring. This is just describing the risk factors of patients for ARDS in patients on mechanical ventilation. New onset ARDS is relatively common, up to 19% of patients that are on a ventilator for over 48 hours. These are patients that didn't have ARDS when they first went out the vent. High tidal volumes and peak pressures are the most common risk factor. In other words, the patients with higher tidal volumes and pressures are the ones that most often develop ARDS. Transfusion of blood products and high net fluid balance also plays a major risk. And they conclude that thus it may be possible to reduce the occurrence of ARDS with careful ventilator and fluid management. So this group suggests that we can actually prevent the disease from occurring if we pay attention to the physiology of the patient. Now, what we're going to, another point, I guess, another concept that we want to discuss is, are these patients that they say don't have ALI, are they really normal? So I went back and really looked at the patient data from these studies that I just showed you. And in Dieterman's study, 44% of the patients had PF ratios of less than 400 with normal x-rays. 24% of the patients had PF ratios less than 400 with abnormal chest x-rays. And the average PF was 347 on a PEEP of 10. So that's really not a normal lung. There's something going on there already, even though they didn't meet ALI or ARDS criteria. The Jahar study, the average PF ratio was 302. Again, not bad, but surely not normal. Gadje had study showed 25% of the PEEP, other patients had a PEEP of greater than 5, and FiO2 is 60%, and PF ratios from 165 to 340. Again, okay, not ALI, not ARDS, but those lungs aren't normal. So the conclusion is that there must be a progressive pathology occurring before the consensus conference definition of established ARDS is met. In other words, the ARDS is a stage disease much similar, very similar to cancer. Right now, we really consider it binary, that it's you either have ARDS or you don't. We think ARDS develops over a period of days, and during this, this development period, these early stages of ARDS, if we act properly, we can actually slow down or prevent the disease. To answer our question, is there a window of treatment? ARDS occurs in the hospital, and therefore there is a distinct window of treatment in which we can prevent ARDS development. And again, ARDS is not binary. There's clearly a pre-ARDS, a pre-pathology where the lung is getting sicker and sicker and sicker. You can watch your patient sort of deteriorating, but they don't have ALI, and we don't intervene with mechanical ventilation until the patient really has established or full-blown ARDS. This figure is from a paper we just published in the Journal of Trauma, and it's really our concept of this pre-ARDS theory. These are the stages that we've just came up and named in the progression of the disease. N stands for normal, stage 1, 2, and 3. Column A, this is an alveolus. This is a capillary, and then there's interstitial space, and obviously in the normal lung, everything's air-filled and there's no edema. No edema throughout the lung. And the classical clinical parameters we're looking for, PF ratio, less than 200, no. Bilateral filtrates, no. And refractory hypoxemia, no. This is stage 1. Now we see we have some interstitial edema here. The alveoli are not flooded yet. There's some spotty patches that probably wouldn't even be picked up on X-ray. And at this particular point, there is no clinical signs or symptoms. Stage 2, now we have a breach of the alveolus. Edema starts to flood the alveolus. Surfactant is represented by these black dots. Is starting to be disrupted, but it's not fully destroyed. And now you're going to see chest X-rays with the bilateral infiltrates, and you're going to get all of the components of ARDS. A patient looks like they have ARDS. PF ratio is less than 200, bilateral infiltrates. The only thing they don't have is refractory hypoxemia. At this particular point, if you intervene properly with mechanical ventilation, these lungs will convert to the normal gas exchange. And then stage 3, that's when you have fully flooded alveoli, fully deactivated surfactant, and then you meet all the criteria, including refractory hypoxemia. Once the lung gets into this state, regardless of what ventilator strategies we try, the patient's going to be very sick, and it's going to be a very difficult time treating them. And as nomenclature, we call this first stage occult ARDS, and we call it that because you don't really know that there's much going on with the lung. We call this a pseudo-ARDS because it has all of the criteria of ARDS except for one major one, and that's refractory hypoxemia. At this early stage, the lung can be converted, it can be regassed, and exchange oxygen effectively. And then lastly, of course, is established ARDS, and this is the one that we all talk about. Very, very difficult to treat with a very high mortality regardless of what we use. So, and our last of our questions was, what are the key pathologic components that comprise this pre-ARDS pathophysiology? Well, we've really broken it down that there's, as everyone knows, the true pathophysiology of ARDS is incredibly complex with multiple organ systems, multiple organs functioning, coagulopathies, immunology problems, permeability problems. It's really a massive, massively difficult pathology to study. But we thought, again, from a practical perspective, what are the components in ARDS pathology that make the patient sick? That the patients that you see at your bedside, they're sick because of what? First off, they're sick because there's an increase in capillary permeability. These capillaries are leaking fluid into the lung, and the lung's starting to fill with edema. So the other thing, the classical injury in ARDS that causes your patient to become sick is the lung starts to flood. As the fluid, edema fluid enters the alveoli, it deactivates surfactant. So this is going to compound the injury. So now you're going to have wet, soggy lungs. The alveoli are going to fill. They're going to gas exchange. The surfactant is going to be deactivated. It's going to cause a further collapse of lung. And it's also going to cause alveolar instability. Without normal surfactant, alveoli don't function the same. And I'm going to show you some film earlier in a while to show you what normal alveoli look like. But these are alveoli from a rat with ARDS. And as you can see, with every breath, these alveoli open and close, open and close. And we and others have demonstrated that this collapsing and expanding, this recruitment, de-recruitment of alveoli with each breath causes a tremendous shear stress-induced injury on these alveoli, which causes more permeability and more edema, more surfactant deactivation. You can see it's really sort of a physiologic circle of death. We hypothesize that if very early, when either before the capillaries start to leak or when they first start, before alveoli flooded, if we apply a mechanical breath with the appropriate pressure time profile, that maybe we can block this whole sequence of events and prevent the disease. And again, we're looking at this from a physiologic perspective in the sense that, well, I'm not saying this mode or this type of ventilation, we're saying this breath. What is unique about this breath that will stop or prevent the disease, and what's unique about the breath that actually causes further injury? So here's what I mean with the difference in this. Well, first, the pressure time profile we calculate is the integral of pressure times time from inspiration to expiration. So the key thing that we have to, another key point that I want to get across is that we always look at pressures and flows and volumes of the lung. We have forgotten to look at the term time. We have to understand the time that these pressures and volumes are imposed on your lung. It is a crucial component in understanding how the mechanical breath injures the lung or protects the lung. So anyway, our pressure time profile, it can be used for any mechanical breath, is the integral of the pressure of time, times time, with time being the sort of the new component that we're really looking at, from expiration to inspiration. This is an APRV breath and just an SIMV breath. And so as you can see, this yellow box here would be the area, the pressure, okay, times the time. So this would be a very high PTP with APRV because the pressure at peak inspiration, at P high, remains for a long period of time, as much as 90% of the breath. The pressure time profile of this SIMV breath would be much different because we have all of this area here where the pressure is reduced. So the amplifying component of time in the equation would be much less, and therefore the value of PTP would be much less. And I'm going to go into showing you that experiments where we show that the effectiveness of this. So now what I want to do is again, being a physiologist, we're going to sort of stay in the realm of physiology. I want to discuss the physiology of preventing ARDS. So what do we have to know? We have to look at the science in order to generate some hypotheses on exactly what we can do with a mechanical ventilator to prevent this disease. So it has been shown that low tidal volume is better than high tidal volume in preventing ARDS development in normal lungs. We hypothesize that this is not the optimal ventilation pressure time profile to truly protect the lung and prevent ARDS. So in other words, we've got this really great clue. You lower tidal volume in patients with ARDS, and you actually improve outcomes. So there's something unique and very important about how we ventilate these patients. And we don't think that just lowering the tidal volume is optimal. We think that we have to look at the entire breath and see what else is there, and then analyze the entire breath and see which components are key. What we hypothesize is that a higher PTP was necessary for the following crucial changes. It's going to keep the lung more inflated to TLC. Now this is going to be very important because it gives structural support to the lung through this term called alveolar interdependence. When all the alveoli are inflated, they sort of act like a support bridge. Each one shares a wall, and they tend to keep themselves open. So, homogeneously ventilated lung is much better, much less likely to be injured than a heterogeneous lung. We're going to rely on the run structure support, also surfactant to prevent alveolar collapse. So with a nice inflated lung, you're going to likely preserve your functional surfactant, and again, keeping the lung homogeneously ventilated. It's possible that we can reduce microvascular permeability. Several studies have shown that. We can increase the interstitial pressure to reduce the fluid. Effectively, why is the fluid coming out of the capillaries? Because there's a positive pressure in the capillaries that's higher than the surrounding interstitium, and it's the fluid, the edema is just going to follow that gradient. If we apply a pressure during a breath, increases the pressure in the tissue surrounding the capillary, maybe that will reduce the amount of fluid flux out of those vessels. It's possible that if there's edema in the alveolus, that we could move the edema back from the alveolus back into the interstitium with applied pressures. It's been shown that unstable alveoli for sure cause a deactivation of surfactant, and surfactant itself has been shown to increase edema. So if we protect surfactant, we really get a twofold win. And cyclic ventilation has been shown to alter surfactant function. And if we do all of these things, if we prevent this cyclic collapse and expansion of alveoli, we would prevent alveolar instability, which would prevent ventilator-induced lung injury. So these are all hypothetical things. These that an appropriate pressure time profile applied early in the lungs might stop the progression from pre to established ARDS. And so I'm going to take all of these apart and say which one of those makes sense and which ones are there scientific evidence to support that these things may be prevented with the proper mechanical breath. So I really think that what we're sort of facing here is we have to find a balance, sort of a yin-yang of mechanical ventilation. How do we protect the lung? We have to balance lung physiology with our knowledge of this mechanical breath, because this mechanical breath surely can protect the lung, low tidal volume ventilation, and it surely can injure the lung. So if we find the right balance between mechanical ventilation and lung physiology, I think we'd be on the right track. And so what we really think right now is that the yin-yang of mechanical ventilation is airway pressure and time. So I'm really going to emphasize the component of time when you're thinking about ventilating. And it has to be these two components that are in harmony in order for the ventilator to be protected. This is a study from our lab. These are subpleural alveoli, and this is ARDS in a rat lung, and here's a rat lung looking with our in vivo microscope. These, you can see a couple alveoli here. This is all atelectasis, this dark red. And we're going to apply the classic 40-40 recruitment maneuver. We're going to apply 40 centimeters of water pressure for 40 seconds. And the key thing to remember, okay, we're looking at the impact of time. The pressure is not going to change. Pressure is going to stay 40 for the entire 40 seconds. But watch how the alveoli recruit in both microscopically and grossly over time. And all we're doing is applying pressure. And what I just want to get sort of really, the point is that it's not just the pressure you apply, but the time that pressure is applied. So we'll start with the alveoli. And you'll see at about 2 seconds, there's a big pop of alveoli. Another one recruits here. And then at 19 seconds, you'll see one recruit right in here. And so again, same pressure. We have not changed the pressure, but there's that. And then for the whole rest of the time, it's going to take this one alveolus this whole time to become fully recruited. So now let's look at the gross lung. And you can see this is atelectasis, and these are the inflated alveoli. In about, again, 2 seconds, we get a big pop. But then watch for the entire 40 seconds. You'll see little buds of alveoli popping open on this lung over time. Remember, the pressure is not changing. So what this really is demonstrating is the incredible impact that time has on lung function at the alveolar level. I guess that's another point I'd like to make is that it's not what's going on at your mouthpiece or what's going on the screen of the ventilator. You have to use that as an idea of what's going on at the alveolar level. So we really have to know what these changes in mechanical ventilation, how they impact the alveoli. But again, so this is the example of how important time is when you're thinking about your ventilator strategy. So what are the components comprising a pressure time profile? Of course, inspiration, time, and pressure. Expiration, time, and pressure. And the rate of change between the breaths, how fast you inspire and how fast you exhale. So right now, what do we usually think about? We're talking managing a patient. We say, well, we got to keep this plateau pressure, her plateau pressure below 30, protect the lung. What's the PEEP? We need a sufficient PEEP to keep the lung open and stabilize. But we never mention the time. What percentage of the breath is the PEEP applied? What percentage of the breath are they at the plateau pressure? The time component is critical. So as an example of we've been studying APRV, and APRV does account for time. Because we set our time at peak pressure and the pressure, and we set the time at expiration. So the one advantage, or the theoretical advantage, I guess it's a theoretical advantage in that it has the time components in the essentially in the dials, is that we're concerned about the time that these pressures are applied with APRV. So. Getting back to the physiology, keep the lung open. Why is it important to keep the lung open near TLC? And again, this is that concept of alveolar interdependence, and you're going to see a lot of sort of older papers because I'm sort of old. And this is by Jerry Mead, a classic paper in 1970. And again, you see all of these alveoli inflated, they all share a wall. And if this alveolus starts to collapse, because they share walls, the neighbors are going to stent it open. Likewise, if this alveolus decides to overexpand, because they share walls, these alveoli are going to compress that alveolus and prevent it from overexpanding and causing injury. So that's why it's important to have a homogeneously ventilated lung. Now, the other thing is, that, and this I alluded to this point, we have to think about what's going on at the alveolar level. So if we ventilate a lung, I'm going to say near TLC just as an example, but a fully inflated lung with a tidal volume of 700, okay? Now, right now we would say, okay, is that 700? How many cc's per kilo is that? You know, what percentage of that patient's cc's per kilo? But let's think about it a different way. Let's think about, okay, what is this 700 ml of tidal volume? What's it doing to the alveoli? So in our fictitious lung here, the big blue circle, we have 7 alveoli, and they're big guys. They all have 400 milliliters. And so what does each alveolus have to do to accommodate that 700 ml? They each have to just give up 100 ml of volume. So as you can see, this tidal volume is not going to hurt this lung at all because alveoli are full. They're all nice and inflated. Each alveolus has to give just a very small amount of gas in order to accommodate that 700. Okay, now if we ventilate the lung at a very low volume, and still we're going to give 700 ml tidal volume. So now we've collapsed 4 alveoli, and the remaining 3 that are open only have 300 ml. Now, so if we try to ventilate this same lung with 700 ml, remember this is the exact same volume. What happens? Now each alveolus has to lose 2/3 of its volume, and one has to collapse totally. So again, for the exact same tidal volume, what's going on at the alveolar level is much different. So we have to take your brains, and as you're thinking about managing your ventilator patient, when you're turning the dials, what's happening to the alveolus? Is this going to be injurious, or is this going to be protective? In this patient, the high tidal volume is not going to hurt them because they have the lung fully inflated. So we concluded it's not just the absolute size of the tidal volume, but rather the size of the tidal volume in relation to the volume of the lung being ventilated. This is also true with pulmonary surfactant. If you can remember from your pulmonary physiology that the pressure to keep an alveolus open is equal to 2 times the surface tension over the radius. So now we've got a nice big fully inflated alveoli. It has a radius of 50 micrometers. If we held a surface tension constant at 50, which is very high surface tension, it's abnormally high. If we had this radius of 50, okay, so it'd be 50, it would be 50 times, or the surface tension was 50, so 50 times 2 is 100, divide by the 50 microns, and would come out to 2 centimeters of water pressure to keep this alveolus open. So if the alveolus is open and full, even with an abnormally high surface tension, it's going to take a very low pressure to keep it inflated. Now we have the same situation. The only thing we're going to change is the size of the alveolus. Now the alveolus is going to be very small, still constant surface tension at 50, but now we're dividing this 50 times 2, or 100 by 5, and now it's going to take 20 centimeters of water to keep this alveolus open just because the size of the alveolus changed. So to summarize, alveoli with a large radius remain inflated during expiration even without a functioning surfactant, whereas alveoli with a smaller radius are dependent on a functioning surfactant system to lower surface tension to prevent collapse at end expiration. What about increasing the interstitial pressure to reduce edema? This is the classic Starling equation. I'm only really going to talk about one component. So this is the equation that you use to see if fluids is going to move out of the capillary. So this is capillary filtration rate, and really it's a combination of the how many pores, how many holes it has in the capillary, which are the reflection coefficients, and the pressures. PC is capillary pressure, and the PI is interstitial pressure, and these are the oncotic pressures. The oncotic pressure of the blood and the oncotic pressure in the interstitium. But we're really going to focus on just is what about changing the pressure in the interstitium? In other words, if we can increase this pressure here, that will decrease the driving pressure across the capillaries. So here if we have the capillary here, alveolus and interstitium, what's going to move fluid out of there? It's like a garden hose. There's a pressure in the garden hose. It's got some holes in it. So since we have a positive pressure in the capillary, it's going to push fluid out and it's going to leak. But if we apply the right pressure time profile, if we put a pressurized gas in the lung and maintain it for a proper amount of time, can we push back the edema? Can we actually reverse the gradient and have fluid actually be absorbed from the interstitium back into the capillaries? So if we apply the right pressure time profile, it's sort of like putting your finger in a leaky dike. We're just applying pressure from the outside to keep the fluid in the capillary where it belongs rather than flooding alveoli. So is there any evidence that this works scientifically? And most of the studies that have been done to date are looking at just one of the components of the pressure time profile, it's PEEP. And although it's not uniform, there are some studies showing that early application of PEEP does not prevent edema. There is many that show a positive effect. So there's 4 different papers that show that in high pressure edema, in other words, if you increase the capillary pressure, if you add a PEEP before you increase the pressure, you'll actually prevent the edema. Also, if you knock out surfactants, high surface tension itself will cause pulmonary edema, and if you add PEEP in a high surface tension situation, you can prevent edema from occurring. Also, if you increase endothelial permeability, 4 papers demonstrated that with increased endothelial permeability, you can add PEEP and actually prevent the edema. You have to add the PEEP before the edema occurs. So we've got many physiologic studies. And again, like Dr. Slutsky said, that this stuff isn't new. The Goldberg study was 1977. So this has been known for a long time. We just haven't really applied it clinically. Most of these are basic science studies, as you can see from the Journal of Applied Physiology. And also high peak pressures. If you, in animal studies, if you increase peak pressure into the 40s, you're going to cause edema, but if you increase the peak pressure to 40 but then add sufficient amount of PEEP, you prevent the edema again. So many physiologic studies demonstrating that application of a pressure time profile, in this case increased PEEP, before edema occurs can actually prevent it from occurring. And although, like I said, 1977, so is there anything new on this issue? And this is a paper published, I think just this month, by Dr. Gattinoni's group. And he was looking at the lung stress strain during mechanical ventilation. And I'm actually going to discuss, we're looking at microstress strain right now. But the key thing for the PEEP was that he was looking at both dynamic and static strain. And strain means how much does the lung change volume for any given stress that's put on it. And here he had, this is a, has effectively the no PEEP, down here at 0 PEEP. And then they inflated up to the same strain, which is 2.5. And then they added, in 2 other groups, they added sequential PEEP. So the strain, okay, the peak strain is the same, the amount of, the amount of pressure going into the lung. The only difference is that the PEEP was different, so the static strain was different. And what they demonstrated was that in the when they had no PEEP, this is lung water initial and end, they saw a consistent increase in lung water in every one of these animals. So the peak pressure is the same, the strain on the lungs is the same. The only thing difference is the PEEP. And here, again, the same strain and no edema. So again, in a study done just this month, or published just this month, again showing that application of PEEP before the lung is injured actually prevents pulmonary edema. And as you know, that's one of our tetrad of injury. And so Dr. Gattinoni concluded that the lung edema forms possibly in an all or none response. It doesn't come gradually. When it comes in a rush, depending on the global strain, but also on its components. Is it static strain or is it dynamic strain. Large static is less harmful than large dynamic, but not because the former merely counteracts fluid exacerbation. What he did show in another part of that study was that it appears that the PEEP prevented the permeability. So it actually prevented the earliest stages of edema rather than sort of the finger in the dike. It wasn't doing that, it was actually preventing the permeability increase. So how about the impact of proper pressure time profile in preventing alveolar instability? Again, this is from our laboratory. And this is a normal lung. You can see that's you can see the lungs being ventilated. This is this is the apical and diaphragmatic lobe. Notice how stable these alveoli are in the 2 dimensions we can see. There's very little movement of those alveoli. This is a normal, stable, healthy lung. This is a rat with ARDS. You can see again the lung edge here. This is the apical lobe and the diaphragmatic lobe. You see, look at these alveoli, how abnormal they are. They pop open with inspiration and then collapse back at expiration. They're doing it here. This is an alveolar duct. The alveoli are all collapsed around the duct. And so what we've shown is that without the proper breath, you cause these very unstable alveoli in ARDS. So now the next question is this injurious? Does this actually cause pathology? And a study in my lab by one of the residents, Jeff Halter, what he did is take 2 groups of animals. He caused alveolar instability by tween-induced ARDS. Then he brought the microscope down on the lung, and he observed the stability of the alveoli. And the alveoli were very unstable after the surfactant deactivation. In one group, he kept a low PEEP, a 5 PEEP, and they remained unstable. In the other group, he titrated PEEP up by looking at the alveoli until he stabilized them. And this is sort of the take-home message. These were the alveoli that were ventilated for 6 hours that were unstable, classic ARDS, neutrophil infiltration, flooded alveoli with fibrin deposits. And this was the lung, again, with the exact same injury, just ventilated differently, more PEEP applied to stabilize the alveoli. And now we have a very more typical, more healthy-looking interstitium. There is some interstitial swelling, but other than that, the lung looked really great. So the point being is that with the identical injury, changing the mechanical ventilation, just by adding PEEP to stabilize the alveoli, prevented further progression of the disease. So this is sort of so here comes, after this big buildup, our novel concepts. Or summarizes our novel concepts. That ARDS is not binary, a construct like pregnancy, but rather a stage disease similar to cancer. So we can't think of just like, oh, he doesn't have ARDS, doesn't have ARDS, now he does. The disease was coming on over several hours or days. Most ARDS occurs in the hospital, so there is a window of treatment for early intervention. If it occurs in the hospital, then we have a chance to prevent it. Application of a ventilator strategy with an appropriate pressure time profile has been shown to positively impact all of the key components of ARDS pathophysiology. And that, again, is the permeability, edema, surfactant deactivation, alveolar instability, which I'm going to list right here. And lastly, we hypothesize, so therefore with this knowledge, we hypothesize that the ventilator can actually be used as a drug to prevent the progression from pre to established ARDS. So what's our rationale? Well, this is the progression of colon cancer. And 50 years ago, if anybody said that they were going to do a colonoscopy on a patient with no symptoms in order to try to prevent colon cancer, they'd say, you're crazy. You could perf the bowel. You could cause all kinds of problems. The patient's not sick. Leave him alone. And now we know it's standard of care. Why? Because it's a stage disease. If we catch the disease early on and cut out that adenoma, no cancer. So what do we do with ARDS currently? Well, we have our normal, and then we have our stages. We have the occult, we have the pseudo-ARDS, and we have established ARDS. And so how do we treat ARDS? I mean, what do we want? We treat the cancer right here, okay? We go in, see the polyps, and take them out. We wait to this. We wait till we see the patient with a full whited out lung, and then we say, well, it's time to apply our low tidal volume ventilation. All we're saying is that why don't we attack preemptively? Why don't we apply our protective ventilation early? So how about starting here? That's really it's not a real difficult concept. It's just really sort of makes sense. And that led to our first publication, which was last year in Journal of Trauma, in which we actually demonstrated that a preemptive prophylactic application of the proper pressure time profile can actually prevent the disease. We have a two-hit animal model. It's very complex. The study goes for actually 3 days. We infect the peritoneum, so they have sepsis, and we isolate and clamp the superior mesenteric artery to cause an ischemic gut. We use Yorkshire pigs, again, who cause a peritoneal sepsis with a fecal clot. We clamp off the SMA, gut ischemia reperfusion for 30 minutes. The study lasts for 48 hours, and you can see my lab looks much more like your ICU than it does a laboratory. We have critical care grade ventilators, Philips monitoring systems. We have all of the standard fluid resuscitation and IV sets. So really, we managed this animal exactly like a patient would be managed in the ICU. So this was our study design. After those 2 hits, after the peritonitis and the gut ischemia, we separated animals into 2 groups, an APRV group and a non-protective ventilation group. Non-protective ventilation, we just put them on a tidal volume of 10 cc's per kilo and a PEEP of 5, and we did not change this other than to increase FiO2 when the animal desaturated. The APRV, I'm going to go through the settings quickly, and I'm really not going to talk too much about APRV settings because Dr. Bashi is going to go into great detail on how to set this breath, this pressure time profile using the APRV mode to get the maximum benefit out of it. But we started with our P high at the plateau pressure on the CMV before we switched. Our P low was always set at 0. Our T low at 75% of the forced expiratory flow volume. The T high was for 90% of the breath, and that led to tidal volumes of around 10 to 15. The animals got wide spectrum antibiotics, early goal-directed therapy for fluids and vasopressors. All animals were continuously monitored in ICU settings. And the one thing that sort of want to point out is look at here. It just so happens that the tidal volumes of the APRV group were as high or higher than the non-protective group. And I'll show you that this had no impact, no negative impact on these animals. So what were the results of our study? All pigs developed septic shock. Okay, we were just treating the lung. The peritonitis was there for the full 48 hours, so we want them to go into fulminant shock. So they had fever, leukopenia, hemodynamic compromise. We had to support them with pressors, positive blood cultures for multiple bacteria. All pigs developed complications of abdominal compartment syndrome, gastric ulcer, sepsis, coagulopathy, and renal failure. So really a classic septic patient that's really going downhill fast. SOFA scores and plasma IL-6 were not different. So in other words, the injury to the animals was the same, regardless of which ventilator strategy, and the systemic inflammation was the same. So in the same scenario, how did the lungs come out? So these, again, the 2 groups, the non-protective group, ventilation is in the dotted line, and the APRV group is the solid line. This is PO2 in hours from baseline to 48. And as you can see, with preemptive application of APRV, our PF ratio was 400 on room air at the end of the study. And the PF ratio of the non-protected animals was almost down to 100 on 100% oxygen. Compliance, the same thing, a gradual decrease over time. And we actually improved compliance with application of APRV. This is looking at the inflammatory mediators and permeability. This is in bronchial alveolar lavage. This is total protein. We measure the total protein in the alveolus as an indicator of how leaky the capillaries are. The more proteins coming out of the blood into the capillary. And we can see APRV significantly decreased the amount of protein in the alveolus, suggesting that it reduced permeability, and also inflammation, significantly reduced amount of IL-6 in the alveolus, suggesting that we also reduced inflammation in these animals. In the first study that we did, the pulmonary edema trended downward, but was not significant. In the subsequent study, it is significant. I'll show you that in a second. Surfactant protein A and B. This is the non-protective, reduced it, injured the surfactant, both these proteins, suggesting that we're causing damage to the surfactant, and this was prevented with APRV. The gross pathology, I think this sort of says it all. In the cut surface of the non-protective lung, we see fulminant pulmonary edema pouring out of the airways. We see a great deal of very red and inflamed lung and a lot of dependent atelectasis. Compare this to the APRV lung that actually looks normal. I mean, it was, I've been at this for 35 years, and this most dramatic study I've ever really performed in that time period. You can see the airways are totally edema free, and the lung looks like a normal lung. By the way, this animal has normal looking lungs. It was 67 liters positive fluids in 48 hours. This animal was as sick as you could possibly get, and yet we pulled these lungs out of the chest just with this preemptive mechanical ventilation. So it's not that the animal wasn't sick. The animal was, had abdominal compartment syndrome, renal failure, coagulopathy, was on 3 pressors flat out, and yet still we preserve the lung in that hostile environment. Histologically, all of this are significant. This is non-protective versus APRV. Fibrinous problems, hemorrhage, capillary congestion, thickening, cellular, all significantly improved. And one of the cool things we found in the APRV group is that we saw these cuffings around the pulmonary artery and distended lymphatics. So we thought this may be part of the mechanism of why the lung was so edema-free, that rather than flooding the alveolus in the APRV situation, that maybe the edema is around the cuffs around the vessels, which makes it harmless, and the dilated lymphatics suggest that maybe the lymph is draining the edema off the lung more rapidly than in the non-protective. So you're probably saying, sure, big deal. You put APRV against a non-protective ventilator strategy and you show a positive outcome. What happens if we test it against the current standard of care, low tidal volume ventilation? And again, this paper just came out a few months ago in Shock, and that's just what we did. We had 3 study groups, APRV preemptively, low tidal volume ventilation using the high PEEP ARDSNet protocol. We applied this exactly the way they do clinically now once the animal desaturated. So this wasn't preemptive. This was put on once the lungs started to get sick, exactly like they would in the clinic. And then a sham, this was, we did all of the surgery. We ventilated them for 48 hours, but we did not cause this peritonitis or the ischemia reperfusion. Again, similar to the big dotted line is the low tidal volume. The small dots are the sham, the controls, and the solid black line is the APRV. Again, with low tidal volume, we saw progressive decrease in compliance over time, and as compared to the control. And again, APRV actually improved the compliance of these animals' lungs for the duration of the study. PF ratio, again, a downward trend as we increase tidal volume and decrease tidal volume in the low and increase PEEP. And you can see the PF ratio in the APRV group on room air was identical to that of the sham control. So not that did it just not, didn't get as sick. They didn't get sick at all. This is our first look at our pressure time profile from that equation that I discussed. And again, because the APRV has a very high pressure time profile because of the extended period of time that the breath is at the P high. And as I showed you from those movies, that the time is a critical component in keeping these lungs open and inflated. In other words, that the alveoli can be inflating over that entire 90% of the breath. And the PF ratio or the pressure time profile of the ARDSNet was very low. I'm going to show you, the next slide is going to be the mean airway pressure, and I want you to show that the PTP is different from the mean airway pressure. So it's not just the mean airway pressure, because it's a product of time and pressure. So as you can see, the mean airway pressure in the low tidal volume group increased as we increase PEEP. That makes sense. I mean, we're going to, but the pressure time profile did not. So pressure time profile gives you a very unique number on what's going on really at the alveolar level. And again, we showed protection. This time we measured E-cadherin, which is an adhesion molecule in the endothelium, again suggesting that the APRV protected E-cadherin, also protected surfactant protein, and also caused much less inflammation in the bronchial alveolar lavage, showing a reduction in IL-6. This time we did see a significant improvement in lung water. This is the lung water in the low tidal volume, and this is an APRV, and this is a sham. It's just really a slightly over sham, and from what we saw, that lung water is in the interstitial cuffs, not in the alveolus. Again, same kind of picture. Very healthy, The lung looks normal. The edema was handled differently in the ARDS-NET animals. As you can see from this cut surface, rather than in the non-protected, we saw most of the edema in the airway. With the low tidal volume and high PEEP, we saw most of the edema in the interlobular space. So you can see these great big separations between the lobes that were just full of edema. There was some airway edema also. But anyway, same type picture. Interestingly, this is APRV, ARDS-NET, and sham. As I mentioned, and shows you several papers, that ventilating a patient on 10 cc's per kilo actually caused a progressive lung injury. And although we didn't see any clinical signs of lung injury, we saw the lung in the sham was more histopathologically injured than the lung with the APRV. So we're showing that even in the normal animal, that a tidal volume of 10 cc per kilo and 5 of PEEP over 48 hours actually causes histopathologic injury. And again, we showed that we significantly increased survival with application of APRV. In this study, by definition, see low tidal volume, our tidal volumes average 5.6. Look at the tidal volumes on the APRV, almost 12. Now, if I told you I ventilated an animal with 12 cc's per kilo and in a protected lung, you'd say I was crazy. But if you think about the physiology, maybe I'm not. So why? Because you saw how big inflated that lung was? All of the alveoli are full. Each alveolus only has to give a small percentage of itself to exchange that tidal volume. So at the alveolar level, that big tidal volume wasn't injurious because the whole lung was inflated. Would have been much different if we had the lung collapsed. Then that big tidal volume would cause tremendous amount of injury. Same thing for surfactant. Big alveoli are going to be, we can support those with much lower pressures than we can with when you let the alveoli collapse. So again, from a physiologic perspective, as long as you think of what's going on in the lung at the time, it makes sense. It really makes sound physiologic sense. And so what we showed is that with this preemptive application of APRV to give us this unique pressure time profile, we decreased permeability, decreased edema, decreased surfactant deactivation, and stabilized alveoli. So we really blocked the 4 major components that make your patients sick. So what's new on the lab? What's new on the home front? We want to study the impact of the mechanical breath more deeply on pulmonary physiology. And we're going to use the lung stress strain calculations. And Dr. Gattinoni has multiple papers. I showed you one earlier on in the talk, where he's really looking at an engineering perspective to see how lungs are injured when you apply certain stress and strain to them. The thing is, Dr. Gattinoni's group is looking at whole lung stress strain, and in his papers he admits that really because the heterogeneity of ARDS, you have to look at the stress strain at the alveolar level, or microstress strain. And so that's what we're going to do. And I'm going to show you some very preliminary data. I don't even know how to interpret it yet. So this is sort of our observation. This was an animal with ARDS on controlled mandatory ventilation, 16 a PEEP. This was on APRV with a 10% T-low, and this was on an APRV with a 75% T-low. And again, Dr. Abashi is going to discuss the settings in detail of APRV this afternoon. And he's also going to show you a video of the impact of improperly set T-lows of 10%. But what we noticed was that the way these ARDS lungs handled the gas, both in the alveoli and in the stars and in the ducts, was different. So that gave us our clue. Like, why? What's going on here? It's they're all at peak inspiration, all at the same pressure, and yet some of them we have distended ducts and collapsed alveoli. Some we have open alveoli and relatively small ducts. So the way the lung is handling that strain is different depending on the ventilatory mode. So what our colleague Dr. Gatto did. This is the anatomy of an alveolar sac, and you have specific alveoli and shared airspace that contacts more than one alveoli. And so what he did with image analysis is he effectively colored all of the shared airspace, which are the ducts, and green, and he colored yellow the alveoli, the individual alveoli, and red was the tissue. So again, remember, this is what it looked like. We had different areas of different sizes of ducts and in alveoli. And after Dr. Gatto's coloration, he can bring up the percentage of gas in the alveolus, percentage of gas in the duct, and the percentage of tissue. And what we showed in our preliminary work, again, this is at peak inspiration. This is the percent of gas in the alveolus. This was conventional ventilation or controlled mandatory ventilation, 5 a peep, 16 a peep, APRV, and spontaneously breathing. These animals weren't on a ventilator. So what it shows is that with both the CMV modes, there's less percent of the alveoli are inflated as compared to spontaneous breathing, whereas APRV, you get almost the identical inflation pattern as we do with spontaneous breathing. And expiration, we see the same thing. In this case, there's less air in the alveolus during expiration, and with the conventional, with APRV, there's almost identical amount of air in the alveolus as there is with spontaneously breathing. Now, again, and so then we took this one step further, and we actually calculated the strain or the percent size change. And really interestingly, we thought that, okay, the spontaneous breathing is going to have the least strain, the least movement. It actually has some of the most movement. It's the strain on the duct, on the alveolus in the green, and on the duct in blue is greater than in APRV and greater than in conventional. So how are we going to interpret this? Surely one of the things we're thinking is that these lungs all had ARDS. The spontaneous breathing was normal. The lung can go through much more strain without causing injury in a normal surfactant situation. So again, what's all this mean? We're really not sure yet. But I just wanted to show you that we're continue to trying to take the lung apart and look at the impact of a mechanical breath, of all the components of mechanical breath on alveolar structures. And so we can bring and give you the evidence like, okay, if you change the ventilator like this is what's going to happen at the alveolar level. And I'm going to end with Dr. Vlar's and Slutsky's conclusion that I started with, that ARDS is no longer a syndrome that must be treated, but it's a syndrome that should be prevented. So the take home, early application of APRV, our animals do great. If you wait until established ARDS, doesn't matter what you do, it doesn't come out very good. So with that, I thank you for your attention, and if there's any questions, I'd be happy to answer.